For those of you who are not familiar with the Meadows has specialized in the treatment of developmental and relational trauma and PTSD using a proprietary model developed by Pia Melody and is integrated across all of our programs for over 50 years. We provide comprehensive care for addictions, dual diagnosis, and primary mental health conditions through multiple levels of CLARE, including inpatient treatment in Arizona, as well as PHP, IOP, virtual IOPs programs available in multiple states. The Meadows is also recognized for our specialty programming addressing problematic sexual behaviors and porn addiction, love addiction, eating disorders, process and compulsive disorders, codependency, relationship and intimacy disorders. All of our Arizona inpatient programs are in network with TRICARE and TriWest, making care accessible to active duty service members, veterans, and their families. I welcome the opportunity to be your point of contact. If you have any questions, issues that I can help address, feel free to reach out to me directly. Without further ado, I would like to welcome Dr. Kevin McCauley, one of our senior fellows here at the Meadows. Kevin has a powerful personal story of recovery that dates back to his time as a flight surgeon in the U.S. Navy. While serving, he saw firsthand how addiction can be treated as a medical and safety issue rather than a moral failing. And it was this perspective that sparked his interest and has shaped his work ever since. He has given thousands of talks worldwide dedicated to teaching and sharing his ongoing research on substance use disorder, some of which we have the privilege of hearing today. Please join me in welcoming Dr. Kevin McCauley.
Thank you, Kirk. I really appreciate it. Welcome, everybody. Happy New Year. I'm very happy to be doing this lecture for you. Those of you who have ever seen me before, welcome back. This is my most up-to-date lecture. If you come to a Meadows program, I'm going to get a chance to meet you. I do the didactic component of our treatment, which is if you come to a treatment program, you're probably going to get a lecture from some doctor. I take a special interest in our military members because of reasons that will become clear. But I just, that's what I got 30 years ago. Those of you from Hawaii, Tripler, you're probably familiar with Dr. William Haining, Captain Haining. He helped me at a very, very critical time of my early sobriety. And so those people that you meet in early recovery, that opportunity to sit down and just talk one-on-one, and that can make a huge, huge difference. So that was a gift I was given, and I try to make sure that our folks have that gift too. So let me try and dive in here. I obviously put way too many slides in the deck. I got excited. It's an exciting time. What can I say? Let's see if this thing loads. It's always something of a miracle to me. Kirk, can you give me a thumbs up if you see a title slide with a sunset in it? Okay, good. All right, we're good to go. So let's dive in. I just want to put in the chat window here a few housekeeping things. That's my email. I keep a Dropbox for Meadows clients and their families that has what I think are the most important current publications. It's a way of getting a very fast library for addiction. So I gave you that link there. This lecture is about this thing I developed. It's kind of silly, called the Periodic Table of the Intoxicants. That's a copy of it. And also, if you'd like to follow along with these slides, this is the slide deck I built for you guys. There is a link to those. You'll have them immediately. I might not get all the slides, but the way I design them is you can read them. So if we miss a few things, don't worry. It's all that information is in there. And then here's the final housekeeping thing. So some of you know my general story. I was part of that generation that saw Top Gun and said, I want to do that. And I managed to not in the front seat, but in the back seat. My eyes kept me from being a naval aviator. But I was a flight surgeon for the main training squadron for the F-18 Hornet for the United States Marine Corps. This is a picture of a Navy complement at that rather large squadron with lots of pilots and lots of students and lots of planes. And you might notice in the background there we had quite a few two-seaters. And so this was just a great job. I loved it. I loved taking care of pilots. I loved every day that I was in the military. I loved putting on that uniform. And so it's a little emotional to do lectures for the military, but I'm happy to. It was just a great time, and it was a great job, and the flying was very exciting. I will be honest with you, I spent most of my time back there either throwing up or unconscious, so it wasn't always pretty. I filled up a lot of gloves. But it was just a wonderful time, and everything was going great, and I had a great relationship with my nation, and something happened. I had to have a surgery, and I got exposed to opioids. And I'm one of those people, one of those hyper euphoric responders to opioids. Now we know more about that. But without getting into the gory details, within about 6 months, I was shooting Demerol. And obviously, that kind of behavior is not commensurate with the job that I had. And so I knew that. I was terrified. I tried very, very hard to quit on my own, and I just wasn't able to. And eventually, the Navy kind of, figured out what was going on. And they were pissed, as you can imagine. And they sent me to their treatment center for drug addicts. They had one back then, back in 1997. It's called Leavenworth. You might have heard of it. And I found myself sitting in the basement of our nation's maximum security military prison. Actually, the first 90 days was in solitary confinement at the Camp Pendleton Brig. That the Navy didn't force me to use drugs. I knew why I was there. But you can see how much happier I am seeing active duty members in our treatment program. This slide gets their attention. They don't have to do that, but I just we've come a long way. I certainly have, and I want to make sure that they have an experience the way I had an experience. Even though my case was handled differently, the military paid for all of my treatment when I got out, and I really do attribute the fact that I'm alive to that very, very good care that I got. But you find yourself sitting in a cell, and there's a picture of Alcatraz, but it looked almost exactly like that. And you start to wonder, am I a sociopath? I mean, how could this happen? Well, back then, the neuroscience of addiction was just starting to come together. There was one comprehensive textbook on addiction medicine. This is my copy, still has my inmate number on it. And at that time, there was this idea, the foreword in this book, but also an op-ed in the New York Times written by the then director of the National Institute of Drug Abuse, Alan Lechner, that addiction was a brain disease. And that was a very, very new idea, very, very shocking back in 1997. And I just grabbed onto that with both hands and held on. So I tried to use that time that the Navy gave me to learn everything I could about addiction. And this is the question that I've thought about and thought about little else over the last 30 years. Now, I'm a doctor, and so the brain disease model of addiction makes sense to me, but we have lots of patients that just does not really fit their experience. So I don't try to force anybody into one category or not, but I do like to discuss it. I think it's helpful for everybody to discuss it. There are some excellent arguments out there that challenge the idea that addiction is a brain disease, and I respect all of them. I think there is a reply that can be made to all of them, but one of them is commonly made that I really want to just point out, and that is that all of this understanding of brain disease has not really advanced treatment and addiction over the time that it's been advanced, and that simply is factually wrong. I think one of the ways we can measure our success is by the expansion of training programs like the ones that Dr. Haining started, and the fact that there now is a repository of people who really like helping people with addiction and recognize the deep reward of helping people get sober. There are a lot of excellent podcasts out there. I kind of listen to these things over and over again because I wish so much that I could be a practicing physician. I wish I could go to an addiction medicine fellowship. I don't think anybody in my situation today would be disrupted, their career would be disrupted in the same way. So that's good too. But I just want to point out my favorite one. If you ever want to really listen to a good podcast, go to this Curbsiders Addiction Medicine and listen to the first episode. It's an interview with a Dr. Ruth Potee from Western Massachusetts. Just listen to the first 20 minutes. And what you will hear is an advocacy and an empathy and a concern and a genuine regard for not just the science, but the patients. And that's a different world. The fact that people could come and really see a doctor behind closed doors and build that therapeutic alliance, that's a new world. It didn't exist when I was sitting in a cell at the Camp Pendleton Brig. But as I read this material, and this is the power of good science, is it can help you see into the future. And it was just like a cloud parted, and I could see, residents and fellows in addiction medicine excited about the material, excited about their patients. And that just is a wonderful thing. There are a lot of exciting debates out there. It's kind of threatening debates, like the whole idea of safe supply. I think that's something that you can do in Canada that might be a little tougher in the United States, and even the idea that maybe abstinence does not have to be an endpoint. I got sober in a very, very conservative frame. So, it's interesting. It's exciting. It's a little scary to take on some of these new ideas, but they're fascinating puzzles to take on. I think that a lot of the time that we have these controversies is we don't have a really good word for the clinical phenomenon of addiction in English. The French have a much better word. They call it toxicomanie. And doesn't that just sound beautiful? Would you rather be a heroin junkie, or would you rather have toxicomanie à la héroïne? It just sounds wonderful. Suddenly I'm transported back to 1880s France and with Charles Baudelaire and symbolist poets. But, I think the word actually gets to the issue at hand, is that these drugs are toxic. Fentanyl is a toxin. And I don't know any problems in environmental public health where you solve a pollution problem by putting more pollutant into the environment. So if there's a frame that I like to turn to whenever I'm confused or I can't figure something out, I like the frame of environmental toxicology, because it really kind of shows that there really are exposures that people can encounter. And if they encounter it at a certain dose and a certain frequency at a certain point of their life, that will bring out certain vulnerabilities that you won't see in the person, say, sitting next to them. So I like to get back to this exposure. I'm going to talk a lot about exposure in this lecture. The period of life that person encounters that exposure, that's going to make a big difference into whether or not they have develop addiction should they be exposed, even in a clinical situation. So in that Dropbox, you're going to find what is our nation's main publication on the neuroscience of addiction. To its credit, it also talks about the neuroscience of recovery. And that's the Surgeon General's report. Came out in 2016, a little while ago, but it still holds up pretty well. It's a thick document. It takes me a long time to get through it, and it's complex. And you can understand that if I put slides like this on the board for people who are 3 days sober, it doesn't make me a lot of friends. So I like to kind of summarize this neuroscience. I think it can be summarized in 3 simple sentences. These are 3 sentences. If you know them, you have an excellent foundation in the neurophysiology of addiction. And I think this is the first important sentence to know about addiction. Something goes wrong in the brain's ability to perceive pleasure, to construct a normal, pleasurable experience. Now, I'm already in trouble here with my oversimplification, so I'm going to put that word in scare quotes, because what we're talking about is a problem in the dopamine system, and dopamine is not the chemical of pleasure. It handles an aspect of every pleasurable experience. I would say the core component of a pleasurable experience. It's that attention getter. It grabs my attention and zeroes me in and tells me this is important for survival. And what we now know is that it's not just good things, not just reward that releases dopamine. Extremely aversive things can too. So when that person has that awful experience that will later consolidate into PTSD, that moment is dripping with dopamine. So I like to think of dopamine as a surprise, good or bad, surprise chemical. And that dopamine system has to be working perfectly if another system in the brain is to work. And that's the system that we use to make choices. So again, I'm going to use that word choice, put it in scare quotes to really stand in as a category for everything that the frontal cortex does. All of those things that we take for granted, they run off the quality of that dopamine signal coming from below. And if that dopamine signal is faulty, then you'll see impairments in executive function. So I think those are the first two important sentences to know about addiction. Uh, oh, okay. I see having some trouble with downloading. Well, we'll take care of that. Don't worry. You will have these slides by the end of the day. I'll make sure that you get them. The third sentence that I think is important to know about addiction involves the cause, which is not genes. Genes are important. They're a big part of the story. Can't tell the story of addiction without talking about family history, but you really have to have something in the environment. You have to have an environmental exposure, and that is the key causal factor, and that I would call stress, but again, scare quotes, severe, repetitive, systematic, cumulative, maybe even inherited stress damages the development of that dopamine system. And so this is something we were all born with, a striatal dopamine system, and it works great. We used to think that it was just in that middle of the brain, but it extends all the way up to the top of the frontal cortex and even into the body, into my immune system. The dopamine system is intimately connected with my immune system. So now we have seen how this system expands. It works great, but it's fragile. And if it's exposed to these toxic exposures, then you're going to see a range of chronic, of different dopamine related disorders that can develop. So that's the intersection, if you like, between depression, trauma, addiction, ADHD. We've got a lot of patients at the Meadows. They don't have a formal diagnosis of substance use disorder. So I want to make sure that there's plenty in this lecture for them too. But I think it helps to know that if you have major depression, you need to know opioids work differently in you. They carry a lot more risk. And sometimes just knowing that, well, it could have saved me a lot of trouble. Let's put it that way. So if I had to put it in a sentence, addiction is a stress-induced, genetically mediated defect in the reward learning system that uses that chemical dopamine to grab my attention and its partner glutamate to lay down a memory of whatever just happened. Can you see that that's the problem in both PTSD and addiction? Way too much salience given to the event, and the memories that are laid down are pathologically strong and probably will require some degree of reprocessing. But when you lose that reward learning system, you lose the frontal cortex right behind it. Sometimes I get no further than this slide right here. There are all kinds of questions, and I just think it's a busy slide. I give you that, but that's where we are, at least in medicine. So I think the people doing this research might look a little askance at my three sentences, but I'll tell you, those will do you right 98% of the time. And this is an idea even that our founder, was understood, and the people that she worked with understood, is that there seems to be a commonality between all addictions and that they have a common trunk and a common root. And at least from a neuroscience perspective, I think my buttons are clicking a little too much up against this desk. At least from a neuroscience perspective, that idea has stood the test of time. This idea that what makes an intoxicant an intoxicant is its factor of releasing too much superphysiologic amounts of dopamine in the reward structure of the brain. That, I think, is the central dogma of the hypothesis that we use in medicine to understand addiction, the dopamine hypothesis. Dopamine is just the entry into this problem. There are going to be lots of other chemicals that are important, but this is, I think, the one merciful thing that nature gave us was this rather elegant and straightforward idea that these chemicals are bound together uppers, downers, strong, weak, legal, illegal, by their dopamine component. And then the power, and this is something that Dr. Patrick Carnes recognized as well, is that there are also behaviors that can do the same thing. The dopamine hypothesis gives you the ability to kind of take 5 steps back and look at the entirety of the picture. So I have a way of sort of summarizing this dopamine hypothesis and all that goes with it. That's the periodic table that you might see there. Again, I'll put these links one more time for those folks who just got here. And I don't know why the color doesn't come through, but what I've tried to do is summarize the whole thing, the whole dopamine, at least the main points of it on a single page. And I think you get the idea is that you can arrange these intoxicants into, classes, and some are, on the left, not as strong, but as you go to the right, they get a lot more potent. Even behaviors are important. And that's the central idea of the dopamine hypothesis. By the way, if you want a very, very good written summation of this dopamine hypothesis, I highly recommend Dr. Anna Lemke's book, Dopamine Nation. She's got a lot of great podcasts out there. This is, I think, the first book I would point, after maybe the big book, the first book I would point to if a patient wanted to know more about that. And so what I'm going to try to do, what I try to do in all of my lectures, is summarize that dopamine hypothesis. I'm going to try to do it in about 10 to 12 minutes, because here's the thing. Once you know it, it's almost impossible not to know it. I think our patients intrinsically know it. I'm just bringing it out by showing them the science. But once you've got this idea in your head, it's almost impossible to unlearn. And it's so straightforward that you can now take this understanding and go out into the world and solve problems that crop up in the news. If you read an article in the New York Times that says that heroin addicts can go back to moderately using heroin, you will know why that's wrong. Why is it that fentanyl is so much more deadly dangerous even than heroin? The dopamine hypothesis can explain some of that, right? Why is it that vapes, electronic nicotine delivery systems, have not been the nicotine cessation product that we really hoped they would be? The dopamine hypothesis is an extremely powerful area of science that can answer a lot of these questions. I know that it's healthy to question the science, but if you see a talk and someone says everything you know about addiction is wrong, no, it's not. This is one of the most stable areas of science. And since I sat in a cell and I was introduced to it by Dr. Nora Volkoff and Dr. Mark Gold, and very brilliant writers who wrote those chapters in the Lowenson textbook, it hasn't changed that much in 30 years. It's gotten more complex. There's a lot more to talk about than dopamine, but here we go. I'm going to try to summarize it. Okay, this is the first study that you need to know, really the one that began all of addiction neuroscience. You've heard of it, you know it. It's the Olds-Milner study from the 1950s. And what Olds and Milner were doing was they were putting probes into different areas of the brain of a mouse, actually a rat. And when they got to this spot, which they called the septal areas, we call it the nucleus accumbens, and they allowed an animal to self-administer a drug, and it didn't seem to matter what drug you used. They all kind of did the same thing if you put them there. It completely took over the animal's behavior. He did nothing else. He would listen to no other survival drives. Even if you put an electrified grate in front of the lever, he would just sit there and fry and press that lever, and in some cases even to the point of death. Anytime you hear the words drugs hijack the brain, this is the study they're talking about, right? And so what Olds and Milner found was that laboratory animals would reliably self-administer drugs of abuse, the same drugs of abuse that humans self-administer. They would do so avidly and even in some cases to the point of death. That's the first study. The next study that I think is important to know about is where they took the probe out and they replaced it with a double-bored syringe. And through the center bore, the animal could self-administer a drug of abuse, again, right there into the nucleus accumbens. But something's going on in the nucleus accumbens. We've got to find out what it is. And so a pump through the outer bore would suck up whatever extracellular fluid was in the nucleus accumbens after the drug was released. And what they found is, regardless of the drug, there was a big increase, a supraphysiologic increase in the concentration of this newly discovered neurotransmitter, dopamine. And if you've ever heard my slide lecture before, I apologize to repeat this, but I really think this next slide is the most important slide I could show our patients, because if you understand it, and I think most folks do, you understand so much about what drives the behavior of people with addiction. It wasn't just the amount of dopamine, it was how fast the dopamine was released into that synaptic gap, right? So they all release dopamine, but some release a lot of it. And depending on that drug, that class, that route of administration, it is really the rate of change in the concentration of dopamine in the nucleus accumbens that is the way the brain recognizes things that are good for survival. In a sense, the brain has a value calculator. It can recognize what in the environment is extremely efficient for survival, and it runs on dopamine. So the slope value of that curve, and probably the steepest curve, is, and for those of you from Honolulu, smoked crystal methamphetamine with cocaine right behind that. Hey, that's not to insult alcohol. Heroin's a great drug. It's just by virtue of their pharmacology and the route of administration, inhaling, that exposure releases the most dopamine the fastest, and the brain was not designed for that. Those spikes of dopamine are deeply, deeply toxic to the brain. By the way, I will leave some time for questions at the end. I have so many slides. I hate to just talk so incessantly, but I'm very, very eager to hear if you have any questions, and we will have time for that at the end. So that, I think, is a key point of addiction. It's in that area of the brain. And so let's go down there. Let's drill down a little bit. Here we go. That green arrow I just showed you, that's this green arrow. And we're talking about the change in concentration of dopamine in this particular synapse right here. And everyone seems to meet there. The reason that cocaine and methamphetamine can release so much dopamine so quickly is they work right there. They have no middleman. Other drugs might come through a back door. They might come through an intermediate chemical, but the nature is that they all end up at this synapse and over-release that dopamine. So just one of the things that alcohol does is it acts on the opioid system and then plugs into the dopamine system. We used to think that ketamine worked just through the glutamate system, but now we understand it resets the opioid receptor system. So this may be a reason for why ketamine can have this rapid reversal of depression that has not responded to first-line treatments, right? Because it acts on the opioid system, but because there's a dopamine component, it will always come with some risk. Cannabinoids are interesting because they come at the end of all of this. Their position in this little map means that whatever signal comes in, euphoria, relief of your social anxiety, treatment for your ADHD even, cannabinoids will sort of magnify that effect. They say, oh, it's even better than that. And so that's why cannabinoids can be the Swiss Army knife of self-administered intoxicants, because whatever you got, the cannabinoids will do a little, good for them at first. Even behaviors can figure into this. So as you can see, it's quite the mess. But this really has helped us understand at least the most detailed part. There's lots of other things peripheral to this slide here, but the idea that naltrexone might be helpful for people with alcohol use disorder because it basically takes the opioid system out of the game and stabilizes dopamine downstream. That is, I think, where we start to get our little bag of tricks. Those medications that we now understand, might be helpful, even though some of them might be intoxicants to help people with intoxication disorders. Now, what our patients want to know is, well, you said that spike of dopamine is toxic. What makes it toxic? Well, it's toxic to dopamine receptors. And so in a sense, addiction is not a volume problem. It's not really a matter of too much or too little dopamine being released into the gap. It's a gain problem, right? It's a problem in the receptors that pick it up. It's not a volume, but rather a gain issue. The person can't hear that dopamine, if you like. In the same way that a person with type 2 diabetes releases insulin, their target cells can't pick it up. And that's the basic defect in addiction. If you want to point with one finger to one particular pathophysiologic defect, right? This is what Dr. Silkworth was talking about when he wrote The Doctor's Opinion. I think these people are different in some important way. There it is. So this is the work of Dr. Nora Volkoff and Dr. Roy Wise at NIDA, one of the most powerful studies out there. If you look at that row of 4 brains there on the left, those are normal brains. Don't have depression, no trauma, never had ADHD, not addicted. They have a nice, healthy, robust population of dopamine D2 receptors. So they have no problems with anhedonia. They've got normal hedonic tone. If you give them an intoxicant like methamphetamine, it's going to release a lot of dopamine, and it's a big feeling, but it doesn't reprogram their lives. The other group of 4 brains, those are the people with ADHD, the child, now the adult, the person with addiction, the person with early sobriety, the person who's been a victim of trauma, the person who has the anhedonia of major depressive disorder. When that spike of dopamine comes along from the intoxicant, it's a very high signal to noise ratio, and the brain grabs onto it, and now we're running. What our patients want to know is, am I permanently damaged? No, not at all. The good news is this system will recover pretty well. It might take a few months, but for the most part, if you can take the insult out, those dopamine D2 receptors will return. If they don't go back all the way, well, maybe that difference is ADHD, and now we're going to need 2 solutions here. But that's the good news. The bad news is I got to take the intoxication out of the picture. And that's why we're not a controlled drinking school at the Meadows. We really, do feel that the end point, at least for a little while, right, needs to be abstinence. And this goes a long way to helping our other patients understand, why are you taking me off my Klonopin? I've never abused my Klonopin. Why are you taking me off my Vyvanse? Well, we're trying to make sure that the treatment for your depression and your trauma, even though you don't have substance use disorder, can do the best job it can. What the future holds for any of these patients, I'm agnostic about, because, and I'm probably going to earn all of my money in the next 30 seconds, we really try to encourage our patients to make as their doctor, if they have if they're in recovery, a doctor who has been specially trained in the unique needs of people in recovery, an addiction medicine specialist. This did not occur. There were only a handful of people when I was sitting in my cell. I'd already met 3 of them when I went to prison. So I knew that there was this idea of addiction medicine, and now we have this wonderful population of young people, and I really hope that our patients will, and we go through the ASAM website, go through the physician finder, really try to analyze, who if in the military, is an addiction medicine specialist. Maybe we can link you up with that person. I could use a lot of help with that from you guys, because I know that there are wonderful professionals. It's just a matter of getting that person to that individual and connecting them to all the things that we're learning about in addiction medicine, whatever comes down the pike, psilocybin, GLP-1s. I want the patient to be attached to that. If they need a rotator cuff repair in 5 years, they need a doctor who can help them, or a provider who can help them through that. But that, I think, is a powerful way to understand not just their experience, but what they'll read in the basic text of Alcoholics Anonymous. So dopamine's role in reward is complex. It handles things peripheral to reward. And this study, which came out during the pandemic, is important to look at too. This study showed that it's not just good things. This is actually something that Roy Wise said way back 25 years ago. But these studies show that terribly awful, aversive experiences also release dopamine. So the idea that dopamine does not have valence, right? It's not good, it's not bad, it's just, hey, pay attention to this. It's important for survival. That's a powerful idea. And so what that means is, at this early level of brain processing, before the signal gets to the amygdala, before that, right, the brain really can't tell the difference between intoxication, and trauma. They're really still the same signal. They won't start to diverge, get their valence until later processing, which I think is one explanation for why you can see this symptomatic overlap. Why does the soldier want to go back to the, I understand why a person would want to use heroin or alcohol again. Why does the soldier want to go back to the battlefield? What is the basis of trauma bonding? Well, there is this tendency. I think dopamine gives us it has a pull to it when the brain is trying to figure this out. There is this tendency not just to re-experience, but also to reenact. I want to be careful because I don't want to blame the person for their trauma, but I think that that's part of the experience. So on that sheet that I gave you there, you're going to find what I call the ends of dopamine. This is a more modern understanding of what dopamine actually does. Yes, it handles things that are rewarding, motivating, but also things that are new, even things that are neutral if paired with the intoxicant, things that almost happened. Right? This is why people with gambling disorder chase losses. To almost win comes with a lot of dopamine. And I got that last one from Dr. Anna Lemke. Things that are numerated and ranked do have a dopamine component to them, which is why social media may belong on this list. So now we can go forward and start to analyze some problems. And so at the bottom of the periodic table here, I've put what are the assumptions of the dopamine hypothesis. These are the things that we can take away from if the dopamine hypothesis is in fact correct. And so these are things that may have to be revised, but they haven't yet in 30 years. And so this would be the first one, and I think it should be immediately apparent that what drives the risk of addiction for any intoxicant is the kinetics of its dopamine release. So now I can start to help people understand that, when we put you on the patch of the gum for nicotine, that's going to handle some of your cravings and withdrawal. It won't satisfy quite like a cigarette or a vape. And that's something we should discuss. Maybe there's an intermediate product. I can't believe I'm saying this, but we can blame the Swedes for snus, or I won't even use the proprietary product. I'm sure they're very popular in the military, because certainly smokeless tobacco was when I worked for the Marine Corps. But if we can just back off that speed of delivery, we're starting to get some benefits. A lot of the harm is in the inhalation. So the speed with which that nicotine is delivered to the brain and causes that dopamine release. And that's why vapes are always going to be kind of in the middle there. If you go to Australia, they have a very, very careful flow chart of how to bring people from cigarettes to a vape and then bring those doses down. So that harm reduction a lot more developed in other countries than we might have it here. But that fits with what we know about the dopamine hypothesis. If we look at this green row, the opiates and opioids, we can see the opiates, those drugs that come directly from the opium poppy, but they, are not quite the same. If you use morphine, right, and that's the main ingredient in opium, it's not a very lipophilic molecule. It'll get into the brain, but it's going to take a little while. So it's going to take a good 15 minutes for that high to really come on. But if you boil morphine in vinegar, then it becomes diacetyl morphine. That's a much more lipophilic molecule. It can rocket into the brain. Here's the thing. Diacetyl morphine is too bulky a molecule to actually fit in the mu opioid receptor. So if you want to be technical, there's no such thing as a heroin high, but the brain very quickly breaks off those acetyl groups. It's morphine again, that can bind. So that product, diacetyl morphine, invented by Bayer, is heroin. And heroin has something that morphine doesn't, has a rush. So the way it comes on, even though it's roughly the same molecule, that matters. And so when a person uses heroin, it comes on very quickly, and then it is sort of metabolized to its products. Eventually it becomes morphine, and morphine will last quite a few hours. And that's kind of the world of heroin that really hasn't, changed that much for many, many, many years. And most people use heroin maybe 2-3 times a day. And then along came this crap. You can see just from the structure of the molecule, we've got a much, much more different product, right? So morphine is an opiate. Heroin is a semi-synthetic. Fentanyl is a purely synthetic opioid invented by the second most famous Belgian ever, after Father Damien, Paul Janssen, who was just a genius at fitting molecules into receptors. He invented a whole bunch of very, very critical medications that we still use. But fentanyl, because of its shape, has certain properties that make it much, much more dangerous even than heroin. So it's extremely lipophilic. It has a very high volume of distribution. All you need to do is get it on a mucous membrane, and it's everywhere instantaneously. And so what the patient experiences is an extremely fast onset of that euphoria. The drug goes where the blood goes, so that's the brain. That's the most perfused organ. And so it's delivered, and the high comes on almost instantaneously. But here's something the brain does with fentanyl that it doesn't do with other things. It immediately starts pumping it out. So the high is on and immediately starting to come off. You don't get those nice few hours that you'll get with morphine. And so the person has to redose. Now, it's not that the fentanyl is gone, it's just entering other tissue compartments. So the person will use and then lose the high, use again, then lose the high, use again and get the high. It's not that the fentanyl is gone, it's building up, right? And then over the next couple days, it will start to leach out of those organs. So really, you're looking at a use of opioids that never happened before. You saw this with crack, you saw this with other drugs, but now you can see people using 10, 12, 20 times a day. I don't care if you've got the best vasculature in the world. No one can shoot drugs 20 times a day. So fortunately, the drug is super potent and you can move back to smoking. But I think you can get the point here. It is the structure of the molecule and the dopamine hypothesis that it can explain why we're in such trouble with fentanyl. And thankfully, those deaths are starting to back off. There's even an article in the New York Times today about no one's really quite sure why, right? So I got all of this from this particular article. I won't go through all of it. I'll just put the slide up here. Really recommend it. It's just fascinating. The pharmacokinetics of fentanyl are what make it so dangerous. Fortunately, we have some good treatments. And one of the things that I do is I keep a very, very close eye on how many people we have with opioid use disorder, because we need to repair their opioid system. The different opioid receptors. What's so fascinating about the opioid system is how widely spread it is. And it's not just a matter of euphoria or analgesia. A great deal of the way we bond is our opioid system. When you take that newborn baby and you hand it to its mother and they form that dyad, that's the opioid system. You can screw with it. You also need to repair it. And so this was an idea that was put forth by the father of effective neuroscience, Jaak Panksepp, that basically what lies at the core of attachment is the opioid system. He was doing experiments on puppies. He would remove them from the presence of their mother. They would call out. But if he gave them morphine, they didn't call out. If he gave them naltrexone, the opioid blocker, they called out more. And he started to think, well, you know what? Heroin addiction looks a lot like falling in love or losing love, right? This is, I think, very, very important moment for a person who's never developed secure attachment when they first encounter an opioid. So the fact that we give buprenorphine is sometimes seen by folks as standing in the way of going to, say, a 12-step meeting. But there's research to show that if you give that person buprenorphine and they're not intoxicated, you're actually giving them a lot of stress buffer, some stress resilience. And they actually, even though it doesn't lower their social anxiety, per se, it makes them more likely to take on social challenges. What's the big challenge when you're newly sober from heroin? Asking someone to be your sponsor. People are more likely to do that. And then having done that, and the sponsor says yes, of course, they are more likely to feel a degree of satisfaction in having completed and succeeded in that act of social connectedness. So this is something I think that's important for understanding things, that a lot of our patients struggle with. Okay, moving on. So the second thing that I think the dopamine hypothesis suggests is that behaviors can do the same thing. So this would be this gray road down there. The worst lecture I ever gave in my life, and my wife was there, so she still brings it up, was in Paris at a slot machine manufacturers conference. And I can tell you, it went over like a lead balloon. A slot machine is a very carefully designed piece of technology to extract as much dopamine as it can. So it's not just putting the coin in and pulling the lever and spinning the reels. If you have the ability to stop the reels, right, by choice, a lot more dopamine. So as you're familiar with, there's a huge problem with within game sportsbook betting. Really, that's the drug that keeps me up at night. Sportsbook betting on smartphones and college age males. We are starting to see people come to treatment with that alone as their use disorder. No real chemical component, right? Make no mistake, those rules are built into the Amazon sales portal. And so perhaps now that you have this dopamine hypothesis well situated in your mind, you can see why this is a terrible idea, right? This is for some people much, much more dangerous an exposure than it would be for normal people. Remember that intoxication can decrease the binding availability, that's the number of dopamine receptors. That dopamine spikes actually sensitize not liking, because liking requires all of those downstream chemicals, the opioid system, the cannabinoid system. That's what a pleasurable experience is. Dopamine's the core component, the wanting of that thing. The gentleman who did this research is Kent Berridge at the University of Michigan. He has, I think, one of the best sentences that's ever been written in science, the neuroscience of addiction. It is possible to desperately, desperately want something that you have consciously come to hate. This is the brain's ability to construct a pleasurable experience coming undone. It's important for our folks to understand that addiction to one substance makes them vulnerable to others. So the person who has an alcohol problem and discovers Adderall, and if they're using too much psychostimulant, can link that to sexual acting out. Well, now we've got a very, very serious exposure that can lead to addiction. That makes sense from the dopamine hypothesis perspective. Addiction drifts over time. The person might have heroin, they might stop on their own, but they may drift to another product that is not lethal, but the proprietary products of cannabinoids are increasing daily. The cannabinoid system is fascinating because it resembles this key molecule that we use to construct membranes. The cannabinoid system is everywhere. Let me show you the cannabinoid system. It's in clotting, it's in vasodilation and vasoconstriction, it's in euphoria, it's in pain, it's in inflammation, it's everywhere. There are very few systems in the body that don't have some input from the cannabinoid system. So these phyto plant-derived cannabinoids, who knows why they're there, but they will affect a wide range of things, and people will start to discover that they can at least adjust whatever problem they are dealing with. So this is something that we struggle with our, well, we don't struggle with it, but we're seeing more of it. We have patients who say, I'm not stopping smoking pot. It's not going to happen. So we need to talk about my trauma and my depression, and you need to back off on the abstinence stuff. And I think using motivational interviewing is very helpful here, helping them understand their endocannabinoid ohm, and the fact that they now may be using some products which are very, very toxic exposures to their own cannabinoid system. I've found that that's worked. We have patients come in, they're smoking a lot, they're starting to get problems, psychosis, hyperemesis. One strategy I've worked is like, okay, let's not talk about the long-term quitting of cannabis right now. Let's just leave that aside. Hey, you're starting to damage your endocannabinoid ohm because of the strength, the severity of this exposure. If you ever want to use cannabinoids again safely, you need to, I think, take a break, let the system hold. You don't want to take on the cannabis culture. You're just going to lose. I mean, it's very exciting and certainly, very slick. The people in these dispensaries are very nice. You don't want to go up against that. You don't want to take on Snoop Dogg. That's a terrible idea. So just roll out of the way. And what more clinicians, I think, are doing is really just kind of, taking on a sort of curious newbie bearing, which is, tell me more about what cannabis gives you, what you're looking for, the value of it. Tell me about some of the problems. Try to get a sense of how much THC is this person really taking in. And then we can turn to some harm reduction things like when you combine flower, cannabis flower, with tobacco, the toxicities of both of them multiply. So smoking a spliff is going to be a little bit more dangerous than using, say, a THC vape. But when you're talking about these kinds of things, I mean, these are extremely potent exposures to cannabis. I mean, look at that. I'm a needle addict. I get it. I get the romance of all of that, but that is a very, very toxic exposure. It's almost a different drug when you talk about all the ritualization that goes on with that. And that's why people are trying, or at least being sold, these more potent products, and problems are starting to occur, right? So this is a tough one. I think it's helpful for folks to know that there are cannabinoid receptors on your vessels and in your heart, and so there is absolutely a connection between major adverse cardiac events and regular cannabis use. And again, to just help people think of the exposure, can you back off a step or two? You will be decreasing that harm. And I think that there's some very, very good harm reduction strategies and materials on the internet. Obviously, for a military population, this is not necessarily going to be appropriate, right? But I won't. I kind of need to wrap up here and make good on my promise to leave some time for questions. I'll kind of keep my eye on the chat window here, and we can start to entertain some of those should you have any. Other assumptions that we can make is that even though these receptors are damaged, practicing normal, healthy, pleasurable activities, releases of dopamine tends to bring those receptors back. So it's important for people to practice pleasure. I know it sounds strange, right? That very often some of these squares on this chart, and I need to be open-minded about this, turn out to be effective treatments for the very thing we're trying to treat, which is addiction. We know that's true for buprenorphine. We know that's true for methadone. We're discovering some of the applications of some of these others. Where we start to get into some controversy is, how do the psychedelics fit into this? And this is, I can't do a lecture now and someone won't bring up, ibogaine or psilocybin. And all I can say is these drugs are not as addictive, and that's a fact, because they don't release as much dopamine. And yes, there is pretty strong research that they can create these very, very dramatic changes, sometimes even with a single dose. And this has to do with their particular activity at that serotonin 2A receptor and less activity at the dopamine D2 receptor, right? Psychedelics aren't as addictive. It's not that they're not addictive, especially LSD releases a lot of dopamine, but as you go down there, you see a lot less of that, right? But the first time that the person encounters that psychedelic experience, the mere novelty of it means that there's dopamine in there. So you have to be careful. Why do these drugs work? Well, they may reopen the social learning window that was closed as a person developed into adulthood. They seem to do different things. They help people with different coping strategies. The word that's often used is psychoplastogen. This gentleman, David Olson at UC Davis, has developed a form of ibogaine that is a psychoplastogen, but it doesn't come with a psychedelic experience. So this is kind of controversial. Everybody always thought that it's the psychedelic experience that gives you the clinical benefit. Well, there's some evidence that that might not entirely be true. But recognizing, I think, the power of these medications, I've got a rule. I don't stand in front of speeding trains. I won't hide the fact that there's lots of research that shows that these medications might be helpful, even for things things like tobacco. Matthew Johnson at Johns Hopkins University has some very, very exciting studies about the use of psilocybin in helping people get off cigarettes. So I wouldn't want to close the door to that because there's so much suffering out there. I will say that when they really start to do randomized clinical trials. You can't do blinded clinical trials, right? You can't blind a psychedelic experience. It's just not going to work. But when they do that and they compare that to other drugs like escitalopram, which essentially does the same thing psychoplastogen-wise, just much, much, much slower, then some of the benefits start to become a little more hazy, right? When psychedelic assisted psychotherapy is done correctly, it's a big job. There's a lot of hours that go into affording a patient 1 hour of psychedelic experience. So it's possible, this is my concern, that psychedelics will be a revolution for people who can afford it. And the people who can't, well, maybe they'll be given a dose and they can go do it in their garage. So I'm worried that psychedelic assisted psychotherapy, if we don't roll it out correctly, will really be a driver of health disparity. And the fact is that there are some very, very charismatic personalities out there that really have, I think, a lot to gain by advocating for psychedelics. So Rick Doblin, bless his heart, has kept the flame alive in the darkest days of the drug war to try to make sure that people understand the potential clinical benefit of things like MDMA or psilocybin. Went before the panel at the FDA trying to say, please allow this drug. But here's the problem. He's a drug user. And I'm sorry, you can't use the drug that you're researching without actually introducing some bias. So, that's a problem. And so there are features, I think, of this particular class of drugs that are unique to psychedelics. And one of them is this sort of messianic belief that if you're standing in the way of this, you have to be destroyed. But there are a lot of people who've worked with these researchers and have recognized problems, specifically women who have been sexually assaulted in this psychedelic state, right? The difficulty that people have maintaining proper clinical boundaries in their patients when using MDMA, right? So I won't go too deeply into this. We're coming to the end here, but there are some problems. I think those problems will be worked out in the long run. I think that this is something that's going to be an important tool 10, 20 years from now. But again, I would just listen to what some of the researchers are saying about the cultism and the hero worship and the unbalanced nature that these drugs can kind of bring out from people. Again, in the American Society of Addiction Medicine weekly newsletter, Anna Lemke came out with a statement saying, this is very exciting, but I'm a little worried that we're getting some of the same problems that we had when we thought that pain was the fifth vital sign, right? So I'll just leave these slides in here. We don't really have time to go into the GLP-1s. I don't have a lot to say about the GLP-1s. The race is on to find something that these things don't work for. It turns out they don't work for Alzheimer's disease. They seem to work for everything, right? But there is research that just came out last month that says that there doesn't seem to be a benefit there. No one's really quite sure why. These receptors are everywhere. They're certainly in the reward structures of the brain. So the best that I can come up with at reading all this research is that it modulates dopamine. It modulates an experience, or at least a part of the experience, of intoxication, specifically satiety, and they do seem to have benefit in helping people reduce their drinking or stop drinking. Even, I was just listening to a podcast, I can send it to you, by a guy who treats methamphetamine addiction in San Francisco, and the last thing he said was, I've put people on these things for type 2 diabetes, and their alcohol use and their methamphetamine use melts away. Wow, that's a hell of a statement. We'll have to see where this ends up. But there's never been a better time to get sober. There's never been a more exciting time, I think, to help people get sober. So I'll just kind of look at some of these questions. Well, thank you very much. Can you explain a little bit more about why you consider cannabis vapes safer than cannabis joints? So if we're just talking about flower, right, maybe there isn't that much difference. Remember, we're in the inhaled intoxicant category, so we're definitely taking on some harm simply because of the delivery of the cannabinoid to the brain. But when people mix tobacco in with it, you actually get a multiplication of the harms of both, right? And this research that was done on the cardiovascular effects of cannabinoids was able to actually separate out the CV harms of tobacco from the CB harms of cannabis alone. Well, it seems when you put them together in a spliff, you get a lot more of that cardiovascular harm or risk than you would from just smoking flower alone. So a person who's actually trying to help an individual, and again, this is not really appropriate for the military, is it? Might say, listen, is there any way you can stop dabbing and go back to smoking a spliff? Or can you go from smoking a spliff to using a THC vape? Or can you actually back all the way to edibles, right? Because with each step, you're decreasing the harm. Obviously, from a traditional perspective, which we still adopt here, we would really want a person to be abstinent at least for a while, take a break for a year or so, and let your natural cannabis system come back. If you ever want to go back to smoking in the way you describe, you need to take a break. You need to let this thing heal because the exposure that you had was really starting to cause you, obviously, some problems, right? All right. Well, listen, we're right at 2 minutes over. I'm sorry I went a little bit over, but I thank you so much for coming. I wish you the very, very best 2026. If I can ever answer any questions, if I can come and visit you, we have folks who can make that happen. I would love to meet you in person, and we're always here as a resource. But I'll turn it back over to you, Kirk, and let you carry us out.
Thank you, Dr. McCauley. Thank you all for attending.